Hi, everyone. Uh, yeah, we'll have that. I'll try to speak up so everyone can hear me okay. Is this all right at this level? A little louder? Okay. And if it's not okay, then we'll turn on the speaker. Okay. So let's try this instead. Is the other lavalier okay, or do you want me to use this? Okay, no, never mind. I'll use that guy. Yeah. I'll use that. All right. So test. See if that's coming on through. Can you guys hear me a little bit better in the back now? Yeah, I was gonna say. Yep. Test. A little bit better. Is that better? Okay, good. It'll save my voice a little bit too. Yeah. All right, guys. So, yeah, welcome. I know many of you, not all, but we're gonna get started here and start talking a little bit about sleep in Parkinson's, which um, I think that almost 100% of folks with Parkinson's disease, regardless of your age, will end up having some trouble with sleep at one point or another. Is the reality, and changes in how we sleep happen as we age anyway. But it's a huge component. One of the non-motor symptoms or symptom categories in Parkinson's disease are problems with sleep, as many, if not all of you know. So we're going to do a little bit of an overview and then jump into kind of the four main categories of sleep problems that we tend to see in Parkinson's disease. Again, is this level of volume okay? Is this level of volume okay in the back? That's a little bit better. Okay, I'll try to keep this at a good distance here. All right, so let's talk a little bit about some of the topics. So sleep is, kind of intuitively a critical component of our health, but even more so than many of us realize, especially when we're younger and we can kind of go long stretches of time by losing sleep or kind of burning the candle at both ends, so to speak. But sleep is a critical component of our health and well-being at all stages of our life, from infancy forward. And so it's not just about adequate duration of sleep. We need good quality, appropriate timing, regularity, the absence of sleep disorders as far as possible. And so healthy sleep is really an important component of normal cognitive mood functioning, immune, cardiovascular, cerebrovascular, metabolic health, a lot of things that we've come to realize in recent years. Let me just set up something here. Okay. So, very good. All right. It's an odd thing. One sec, guys. Okay. So, more and more research in recent years has shown us that chronic sleep deprivation is associated with a number of adverse health problems. So, this is not an all-inclusive list. Obesity, diabetes, high blood pressure, heart attack, stroke, so cerebrovascular problems in general, depression, anxiety, alcohol abuse, and much more. So it's a critical component of our health. Again, that seems to be a rather intuitive concept, but a little bit better there. That seems to be a rather intuitive concept, but even more so in the context of Parkinson's. So let's talk about kind of what's normal in brief. So trying to get these things synced up here. So our normal aging is, I have a few different windows here. Okay. So normal aging is associated with changes in how we sleep, and that's unfortunately a normal component of aging for all of us. That we get changes in our circadian rhythm. So our circadian rhythm is this system. Is that a little bit better? Our circadian rhythm is a system that maintains this a number of different normal metabolic and physiologic functions in day-to-day life, including our sleep. And so there's sort of a timing, not just associated with the sun coming up and going down, but there's a larger sort of schedule built into our brains that changes as we age. We unfortunately develop decreased secretion of a critical hormone that's a component of our sleep schedule called melatonin. We have a decreased ability to maintain our sleep as we age. This is all just normal parts of aging. So we have more a higher tendency to wake up in the middle of the night for longer periods of time. And that's not just related to having to get up and use the restroom, but also just spontaneously. We tend to get sleepier earlier in the day. We tend to wake up earlier in the morning. That's part of that circadian rhythm change. We overall have a shortened duration of how long we sleep. These are all normal things. And then we have less what we call slow wave sleep. So when we go to sleep, it's a very structured activity in our brains. There's a number of different stages, as many of you may have heard about, what are called the stages of sleep. And if we look at someone's brain waves while they're sleeping, we see our brains go through a number of different sort of structured activities, so to speak, in these phases that creates what we call the sleep cycle. So when we go to sleep, our brains go into a number of different cycles of different types of what we call waves, brain waves, basically, and that cycle goes through early and sort of light sleep, and then deeper sleep, what we call REM sleep, and we'll go into that in more detail later. And then it recycles through the course of the night, and it goes through that several times. And so we have deeper components of that are really critical to our health become naturally shortened. And so, unfortunately, these are all the joys of aging for all of us. But then we have all this at baseline, and with most of us developing Parkinson's disease later on in our lives, we have this in the background, and then we develop Parkinson's and all the troubles that come along with sleep as a component of that. And so let's talk about kind of the four main categories of how Parkinson's disease impacts our sleep on that background that I just mentioned. So we have, broadly speaking, insomnia. And insomnia is a really broad category. We'll talk about that, all of these in more detail in just a second. Sorry, I'll try to keep the mic at a reasonable distance here. We have problems with excessive daytime sleepiness. So we not only have troubles with staying asleep over the course of the night, getting enough sleep, but then often we have troubles with getting sleepy during the day. And the two are not as related as you might expect. We also have in many individuals, not all, but many, a problem called REM behavior disorder, or sometimes called REM sleep behavior disorder, RBD for short. Talk about that, of course, in more detail. And then a very common, but not ubiquitous problem is something called restless leg syndrome, something that many of you likely struggle with. And we'll go through that in a little bit of detail. But the majority of what we're going to talk about is really insomnia and excessive daytime sleepiness. These are by far and away the most common problems that I run into in terms of quality of life, impact on motor and other non-motor symptoms in Parkinson's disease in day-to-day practice. So let's talk about insomnia in Parkinson's disease. So there's, broadly speaking, a couple of different categories of insomnia in Parkinson's disease. We have, or in general, I should say, we have problems with sleep initiation, so troubles getting to sleep. And then we also have troubles with staying asleep, or when we wake up, getting back to sleep. That's what we call sleep maintenance, sometimes called sleep fragmentation. And these are the two broad categories of insomnia in general. Now, in most just normal, healthy individuals that go into their primary care doctor's office or into a sleep clinic, sleep initiation is by far and away the more common problem, getting to sleep. Many of the strategies that we utilize in routine primary care practice and in a sleep clinic are focused on sleep initiation. So different types of therapies to help us get to sleep and work on sleep hygiene, falling asleep in the first part of the night. Most of the medications that we have available to us, prescription, by and large, are focused on getting us to sleep. But in Parkinson's disease, by far and away, the most common problem is actually sleep maintenance insomnia, not so much sleep initiation. It still happens, of course, as many of you know, but by far and away, the more common problem is that I hear in day-to-day life, in practice, is, doc, I don't have any trouble getting to sleep, but I sleep for 3 or 4 hours. I get up and I can't get back to sleep. Or I get up, I go to the restroom, and then I can't get back to sleep. Or I go back to sleep for a half an hour, and then I get up again, and then so on and so forth. So you have this fragmentation of sleep. And that is a really, really common problem. So why does this happen? There's a number of different problems. So number one, neurodegeneration. So Parkinson's disease is a degenerative disease of the brain, very slow moving, but it actually physically damages certain components of the brain, again, at a microscopic level. And many of the centers that are damaged that lead to motor symptoms of Parkinson's disease, so tremor and stiffness and slowness and all these things, as well as many of the non-motor symptoms, mood troubles and a list of other things, are referable to neurodegeneration, and sleep is no exception to that. And so the mechanisms that allow us to get to sleep, stay asleep, and maintain our normal sleep architecture, in addition to those baseline troubles that we have as we normally age, those are affected by the degeneration in Parkinson's. So it's kind of an inherent problem in the disease, number one, but then there are other more dynamic things. So what we call motor fluctuations, as many of you experience, where we use medications to manage the motor symptoms in Parkinson's. So things like levodopa and medicines that mimic levodopa and so on. We try to manage these symptoms of stiffness and slowness and tremor and all these things, but because of the nature of the disease and the nature of the medicines, those medicines only last so long, right? And so we have ups and downs in motor symptom control over the course of a 24-hour period. And unfortunately, the dopamine system doesn't really know if the sun is up or not. And so medicines wear off overnight, and that often affects our ability to sleep or stay asleep. So when we go to sleep, when we are genuinely asleep, our motor symptoms are gone. Right? So our tremor, our stiffness, our slowness, all those things are basically reset. The part of our brain that's not working in Parkinson's disease is basically asleep as well as the rest of our brains. But a normal part of sleep is, as part of that sleep cycle I briefly discussed before, is waking up throughout the course of the night. So all of us wake up many, many, many times throughout the course of the night, just a little bit. Not enough for us to consciously be aware of it, but enough for our brains to wake up and then go back to sleep. That's a normal sort of thing. But if our medicines have worn off in the course of the evening and we wake up in the middle of the night just enough for our brains to wake up and for our tremor, for example, to start again, tremor starts thumping against our chest, for example, and then that really wakes us up and then we're awake. And then we have a difficult time getting back to sleep because motor symptoms are keeping us awake, or stiffness has reemerged, and now we're awake, we're uncomfortable, and it's difficult to get back to sleep. And so one of the ways that we try to address this is by using longer acting forms of medicines that affect the dopamine system, redosing medicines over the course of the evening, which is a practical problem, of course. So motor fluctuations are a problem. Dystonia is a problem that affects many, but not all individuals in Parkinson's disease. And this is really part of motor fluctuations as well, where some folks have painful muscle cramps, often in our legs or feet, where we have basically too much signal being sent from the brain to certain muscles kind of statically. So we get muscles just contracting, and we get curling of our toes or twisting of our feet, or cramping in the muscles of our legs, that sort of thing. And that can be painful. Again, that's often related to levels of dopamine dropping over the course of the evening, and that can wake us up or, again, keep us awake if we already wake up. And so that can be a real problem for some folks. Let's see. Dyskinesia is a problem in some individuals. So we tried to dose medications, but in some individuals, we have excess movement along with improvement in that stiffness and slowness, and that's called dyskinesia. Not everyone has dyskinesia. These are these dancing, wiggling movements that some people have as part of what we call peak dose side effects of medicines like levodopa, and that can keep people awake sometimes. And then nocturia, fancy medical term for having to go to the restroom in the middle of the night, having to empty our bladder in the middle of the night. That's a normal thing. Our kidneys, they don't know whether it's morning or night. By and large, they kind of do, but we still make urine over the course of the night, and our bladders fill up. We have to go to the restroom, and that's a normal thing at all ages. But as we age, both in men and women, our urinary system changes, and we often have to go to the restroom more often through the course of the night. But especially in the context of Parkinson's disease, the system that controls how our bladder empties, that system is not working like it used to. And so having to go to the restroom many times over the course of the night, we go a little bit, don't empty our bladders completely, and then go back to sleep, have to wake up again half an hour later. This is a common problem. So sometimes we have to use medications to address that, in addition to other conservative strategies. All right. So just a quick pause. Can you all hear me okay with the way I'm talking? And so a little bit higher. Yeah, I have to hold this a little bit closer like that. And is this pace okay? Am I going too fast? Okay. So, all right. If at any point it's not clear what I'm saying, or if you have a burning question, just stop me. And trust me, we're going to make plenty of room for questions at the end as well. But feel free. It's really informal. Feel free to stop me. Okay. So how do we go about treating insomnia in Parkinson's disease? So I already hinted at the first thing here: medication adjustments. So when someone comes to me and says, I'm waking up in the middle of the night and I can't get back to sleep, one of the first things that I want to look at is medications. Like I said, are medications, levodopa or other medicines that mimic levodopa, are our dopaminergic medications wearing off over the course of the night? And is that the main driver? So classic problem is, okay, doc, I take my last dose of levodopa at 9 or 10 p.m. and then I go to bed. And I sleep great for that first half of the night. And then I wake up at 2, 3, 4 a.m. and I just can't get back to sleep. I get up and I have to start my day. That's a classic problem. Part of that, waking up at 2, 3, 4 a.m. is part of normal physiology, especially as we age. But that trouble getting back to sleep that some folks really struggle with is often referable in part to medicines wearing off. Because again, dopamine only lasts so long. Even if we're using long-acting forms of dopamine at bedtime. And so no matter what we do, I don't really have good medications to last over the entirety of an evening. And so the dopamine is going to wear off. And while folks often don't really notice that problem in the early years of Parkinson's disease, and some folks never really notice it, it's a really common problem in the more moderate to advanced phases of the disease for folks to really have trouble with this. So then often one of the first things that I will look at is, okay, when we wake up, maybe we need to take an extra full daytime dose of our carbidopa levodopa or whatever medication we're using. And sometimes we just need to do that on an as-needed basis. Sometimes it's such a consistent problem every single night that we have to kind of schedule a dose in the middle of the night, or wake up a little bit earlier, wake up before, actually schedule a timer in the middle of the night before we have already worn off, we're already really uncomfortable, our tremor is back, our stiffness is really bad, our dystonia is causing terrible cramps. Maybe we need to wake up on a scheduled basis in the middle of the night, several hours before that happens, take an extra dose and kind of get ahead of the problem so that we can sleep a little bit better through the remainder of the night. We might still wake up, but folks will often be able to get back to sleep. So that's a common problem and a common sort of first troubleshooting solution, if that makes sense. some of the ground rules to waking up and taking an extra dose or scheduling a dose in the middle of the night is we want to make sure that we don't turn on bright lights or anything. We have the medicine ready to go, just right at the bedside. A little glass of water, so we can just kind of have a very soft alarm, just enough to wake us up. Take a dose, take a sip of water. Don't turn on the light because light wakes up our brains, and then go back to sleep. And that's kind of the goal. That doesn't work for everybody. Nothing works for everybody. That's as I'm sure many of you have heard me say over and over and over and over and over and over. Everyone is very different in this disease. So a lot of this comes down to troubleshooting. Right? There's no one size fits all, and that can be frustrating, especially when you're exhausted. You're not getting good sleep night after night after night, and you're seeing your doctor, once every 3 or 4 or 6 months or what have you. And we try these things, but often it takes sort of an algorithm. Let's try this, then let's try that, then let's try that to find what works for your body. So, so medication adjustments is a really common problem. There's more to say about that, but that's kind of the core, some of the core thoughts. And working with me, many of you are my patients or your other doctors, really important to troubleshoot it. So sleep hygiene. Let's talk briefly about sleep hygiene. What does that mean? So this is more of a pertinent component of getting to sleep in the early part of the night. So again, when an otherwise healthy, 30 or 40 or 50-year-old, comes to our clinic and says, I can't get to sleep at night, one of the first things we want to look at is sleep hygiene. Folks will say, well, I'm having a beer at night and I'm eating my dinner with that beer, and then I go to sleep an hour later, and I just exercised, and then I, fall asleep in front of the TV, and all these things, and the bedroom's too hot, I don't have the AC on, all these things. There's all these problems with we need to make sure that our sleep environment is conducive to sleep, that we're not waking up our brains with excess bright light right before we get to sleep, that we're not waking up our bodies with too much exercise for some folks right before we go to sleep, or alcohol or caffeine late in the day, all those sort of things. There's a whole list of things that are easy to look up, but by and large, in Parkinson's disease, these are not usually major problems. Going to sleep at the same sort of time, the same schedule, going to sleep at the same time every night, waking up at the same time in the following morning, generally speaking, these things are not usually problems. Most of my patients are not going out clubbing until 3 a.m. and and things like that. I mean, some of you maybe, but you see what I'm saying. So there's a lot to say about sleep hygiene, but by and large, it's not too much of an issue. It's always worth reviewing, and I often will, but it's not usually the major issue here. Again, most of us with Parkinson's don't have too much trouble getting to sleep in the first part of the night. But when that still happens, and when we do, it's something worth reviewing. In brief, so manage nocturia. Again, having to urinate in the middle of the night. So a few basic things are not drinking water up until we go to bed, i.e., trying to avoid as much in the way of fluids, in the 2 or 3 hours before bedtime. I'm always harping on all my patients, and many of you will know this, that we need to stay really well hydrated for a litany of reasons throughout the course of the day. But to a point, like within the first 2/3 or 3/4 of a day, we want to really stay hydrated. But we want to back off on that before we go to sleep, because when we drink water, our kidneys are going to be, making more urine as a result of that, which is good, keeps our kidneys healthy and our blood pressure up and all sorts of things. But we don't want to be doing that overnight more than absolutely necessary, right? So that's a basic thing. Seems like it goes without saying, and it generally does, but that's an important thing. But there's also medications that we sometimes use that help with this problem. A class of medicines known as anticholinergics, which help with many individuals, not all, but it's something worth looking at. Often, when we have really serious problems with this, and we're waking up, going to the restroom 5 or 6 or 7 times a night, often I'll have folks see a urologist or a urogynecologist for my female patients, because it's often more complex than just Parkinson's disease. There's other anatomical changes that happen for all of us, men and women. And so often they can be really helpful. So managing that is a really important thing, as you may imagine. And then, so managing anxiety and depression. It's an often overlooked thing in general, but also an overlooked thing in the context of sleep. So clinical anxiety and clinical depression are extremely common components of Parkinson's disease. They're common things anyway, but they're common components of Parkinson's disease as well. And supplementing dopamine in the brain can help with these a little bit, but it's incomplete. Identifying and treating these things is a really, really important thing. And in my own practice, I try to be really aggressive about this, about identifying that, but it's an important thing to identify. It's when we say, this is an important thing, that when we say anxiety and we say depression, clinically, those things mean different things than how we use those words in everyday just language. If I'm saying, "Oh, I'm feeling anxious today because I have a talk to give to a group of people," that's different than clinical anxiety. If I'm feeling down or blue or depressed, or I'm feeling a little depressed today because of X, Y, or Z, that's what we use in day-to-day language is different than what we mean when we mean really clinical depression. And I preface that by really to emphasize the fact that these things can manifest, especially depression, in very different ways in different people. So sometimes depression can cause folks to feel sleepy all the time, or the exact opposite, to not be able to go to sleep at all. Anxiety often causes us to sit there and just be awake, and our minds are running all night. And we're worrying, we're ruminating about things, or we wake up at 2 a.m. and we're ruminating and thinking about and worrying about a trillion things. And so these are ways in which, and there's more to that, but these are ways in which this can really impact our sleep. And so identifying these things is really important in general for many reasons, but especially when it comes to sleep. And sometimes it's all we need to do. So sometimes we'll get folks on medicines that help with both of these. And it's all we need to do to really make a huge impact on sleep. That's true outside of the context of Parkinson's disease, of course, but these things are such common components, non-motor components of the disease, that is really important to identify. So it's an important thing to think about and to be open to. And then I say here, just in general, we have to be flexible. So some of us will wake up at 2 a.m. or 3 a.m. and be awake for a couple of hours and then be able to get back to sleep for an hour or two and then start our day. But if you wake up and you're feeling okay, and it's not really having too much of an impact, and then we can make up an extra hour or half hour of sleep in the afternoon and we feel okay with that, that's fine. We can be flexible with that. There's no one size fits all. That whole myth of we have to get a solid 8 hours of sleep unbroken it's not a physiologic thing. That's not real. I generally want to shoot for a total of 8 hours of sleep in a 24-hour period, but everyone's built differently. And so generally speaking, if we're getting 5, 6 hours of sleep or, in total and beyond, and we're feeling good, that's okay. Everyone's body is very different. And so if we fall asleep in front of the TV at 8 and then wake up at 2 or 3 a.m., that's a really good chunk of sleep. And if we get back to sleep for half an hour or an hour, and then we get up and we start our day and we're feeling okay, that's fine, right? So that's fine. There are normal ebbs and flows in how our brains normally get sleepy, wake up. And so getting to sleep when the sun goes down, getting sleepy, and then waking up again middle of the morning, 2, 3 a.m. That's kind of a normal physiologic thing. Getting sleepy again at 1, 2 p.m. in the afternoon, especially after lunch, that's a normal thing as well. So we have to be flexible with this. And while I'm on the subject, I often will recommend a nap in the early afternoon. That can have a huge impact, not only in terms of adding to our total amount of sleep throughout the course of the day, but it can really have a very recharging, both as far as motor symptoms and cognition and emotion and just energy levels, huge recharging effect. And so I'll often almost kind of prescribe a nap in the early afternoon for many of my patients with Parkinson's, as many of you know. Only a few ground rules with that is that we don't want to sleep too late in the day or too long, because then we're going to be eating into our sleep schedule at night and be kind of resetting that backwards. And so generally speaking, the early afternoon is a good time to be sleeping, and no longer than 30 to 60 minutes. There's some folks who will sleep 2 or 3 hours and then Doc, I can't get to sleep until 1 a.m. Well, we need to try to reset that. We generally want to be doing the majority of our sleeping overnight, if we can. Again, even with that, we still have to be flexible. Everyone is built differently at baseline and with Parkinson's. So, okay, let's talk about excessive sleepiness or excessive daytime sleepiness in Parkinson's disease, another really common problem. And one of the first things you would think about is, okay, we're not getting good sleep overnight for many of us, and so we're sleepy the next day, and the daytime sleepiness is the main driver, or pardon me, the insomnia overnight is the main driver of being sleepy during the day. Funny enough, it's not entirely the case. It often can be, but it's not. It's often more complex than that. So again, in Parkinson's disease, it's a different situation than someone who is 30, 40, 50. They're not getting sleep overnight, and then they're sleepy during the day. Okay, that's kind of a different story. We have other things. So there's a few different patterns that we tend to see with excessive daytime sleepiness during the day, kind of 20,000-foot view here. So intermittent sleepiness, some of my patients will get really drowsy, in the mid morning or the early morning. They take a nap, they feel better, then they get drowsy again in the afternoon. That's a pattern. A common problem is we take a dose of our medicines. Anything that is or mimics dopamine can sometimes cause really prominent sleepiness as a side effect. And so sometimes that'll be a really limiting problem, and we need to really make adjustments to the medication regimen to account for that. But sometimes it's minor, and folks will say, okay, I'll take my levodopa, I'll sleep for 20, 30 minutes, I feel great, and then I'm good to go for the next 4 hours. And then it happens again. And so, again, we have to be flexible in that. Sometimes that works for folks, but intermittent sleepiness can often be a medicine-related side effect in Parkinson's disease. Not in everybody, but it's a common enough problem. Again, we talked about the circadian rhythm shift that happens normally as we age, and then a little bit more so in the context of Parkinson's. Okay. And then, so we get sleepy earlier in the evening. So whereas we used to be able to stay up until 10 or 11 p.m. or what have you when we were younger with the rest of the family, now we're falling asleep in front of the TV at 8 or 9 p.m. And that's a normal thing for many people. Again, we have our dinner, we have our evening medicines, we have circadian rhythm shifts, and we fall asleep too early, or earlier, I should say, not necessarily too early. Depends on the individual. But that's another pattern of excessive daytime sleepiness. And then there are some individuals, especially those with older age, much more advanced Parkinson's disease, more cognitive impairment. Many people will develop significant cognitive impairment or dementia with the much more advanced phases of Parkinson's. And we just tend to see this a lot more where folks are sleeping 12 or 14 or 16 hours per day, where we sleep great all night. I ask you, how are you sleeping? Oh, yeah, sleeping great. I go to sleep. I wake up 10 hours later and then eat breakfast and then go right back to sleep. And then taking 2 or 3 hour naps several times throughout the day. And so we think that that's a component of the changing brain with much more advanced Parkinson's disease. But that's a pattern that I see not infrequently. But again, it's typically in the more advanced phases of both age and Parkinson's. Again, none of these are consistent. Everyone is very different. You're going to hear me say that over and over and over. Okay, so we talked about some of this already. So with the intermittent sleepiness, medication effects is a really common problem. So dopamine, so levodopa, dopamine agonists, so the medicines that mimic dopamine, and the other sort of adjunct medications that we use to support dopamine in Parkinson's disease commonly cause some degree of drowsiness. Sometimes it's really, really intolerable. Some folks, it's just a little bit, it's just mild and it's not that bothersome, and everything in between. And so when we have really prominent troubles with this, one of the first things that I often try to do is change from kind of short-acting medications to longer-acting medications. It's often a peak dose problem. So you take a dose of a medicine, any medicine, it comes up in our bloodstream to a certain peak level in our bloodstream, and then it comes back down. And medicines that are absorbed rather quickly and then metabolized quickly will have more of a sharp peak in our bloodstream. And so we'll typically have more peak dose side effects. Drowsiness is one of them. Dyskinesias or other, the list goes on. But if we're having a lot of drowsiness, when someone says, okay, doc, I'm taking two tablets of my immediate release carbidopa levodopa, and it really, really helps with my tremor and slowness, but gosh, I just get knocked out for an hour after the dose or for several hours after the dose, and it's just not tolerable. We're not improving your quality of life, and that's the whole point of these medicines. Then sometimes switching to a medicine that is a version of it that's absorbed slower and over a longer period of time can solve that problem. That can come at the cost of symptom control sometimes, but there's lots of ways of troubleshooting. And so that's one of the first things that I will think about. So sometimes it's just a kind of pharmacokinetic problem that we can solve. Not in everyone, though, not in everyone. So medication effects. Sometimes taking more doses of medicine, of levodopa, say, throughout the course of the day at smaller amounts can help with that problem. Often there's drawbacks to that, but that's something that we will sometimes try. Sometimes we consider using medicines to actively combat that problem. So medicines that are actually awakening medicines that are stimulating. That's not typically a really successful approach. Once in a blue moon, when we're really desperate, we will consider that. But that's why it's not a really common or successful approach, is actually trying to combat the side effects of the medicine with another medicine that actually wakes you up. Again, there's a role for that on occasion, but it's not usually a good approach in my experience. Sleep apnea is a common problem. It's a common problem in general. This is more or less a consequence of human anatomy. So in many of us, mostly depending on what sort of anatomy of our throat, of our chin and our throat we were born with, and then sometimes related to to excess weight, so obesity, that sort of thing. What can happen in sleep apnea is where we fall asleep and then all the soft muscles of our throat kind of relax. And that happens to all of us. But sometimes our anatomy is such that they relax enough to close down our airway temporarily. And that blocks the flow of oxygen. And so we stop breathing for a short period of time, and it's enough to wake up our brains just enough where we're not really consciously aware of it usually. But that interrupts that normal sleep cycle. And then you go back to sleep, and then the muscles relax again. And it goes on and on and on. That can happen multiple hundreds of times a night. And then you wake up and you feel like you slept through the night, but then you feel exhausted. And then you fall asleep very easily throughout the course of the day. So that's sleep apnea. That's what we call obstructive sleep apnea. There's a few other forms of that as well, but that's the most common one. And this is by and large not too common of a problem in Parkinson's disease, but in particular, but it's just a background thing that we often have to go looking for because there's ways to treat it. So this is a really common problem that's worth looking for, that's worth screening for. And the way we look for this is with sleep studies. So usually we start with a home sleep study where we just give you a few sensors to take home, sort of strapped to your nose and your finger and your chest, and just monitor normal night's sleep and see if you're stopping breathing over the course of the night and if your oxygen levels are dropping over the course of the night, because there's ways to try to address that. And that can make a big difference sometimes in excessive daytime sleepiness and overall sleep quality and cognition and all these things that come along with sleep apnea. But it's just, unfortunately, it's just a consequence of human anatomy, by and large. And then just briefly, excessive daytime sleepiness, EDS, versus fatigue is a difficult thing to sort out sometimes. So daytime sleepiness is sleepiness, but then there's often, especially in Parkinson's disease, just fatigue, which is a kind of a poorly defined and difficult it's a difficult problem to identify the root cause of, but it's a hugely common problem in Parkinson's disease. And we often don't exactly know why that is, why it happens in the first place. But sorting out what is excessive daytime sleepiness, i.e. from like medicine side effects versus just background fatigue, can be a really challenging thing, and they often coexist. And so while I don't have really great treatment strategies for fatigue, we do for excessive daytime sleepiness, as we're talking about now. And so, something that you'll sometimes hear is trying to sort these out is that if you sit down in a chair or be on the couch for 10, 15 minutes and you conk out very easily, that's kind of excessive daytime sleepiness. But if you're sitting down and you're able to carry on a conversation or watch TV or read a book for an hour or something, and you're still just feeling fatigued, you don't have that get up and go, that's more fatigue, right? And so they often coexist, but sorting those out can be sometimes a challenge, but an important one. Let's briefly talk about sleep attacks as well. So this is kind of part of medicine side effects. So there are some individuals who take medicines designed for Parkinson's disease or restless leg syndrome, medicines that mimic or which replace dopamine in the brain. And for some reason, some people will get not just excessive daytime sleepiness, but sometimes these episodes of irresistible sleepiness where they either fall asleep without any warning, just blackout, no warning whatsoever. And it's not blacking out, it's not loss of blood pressure or anything. It's genuinely falling right to sleep. It's very similar to what we kind of see in narcolepsy. Mechanisms are different, we think, but it's a similar phenomenon in severe narcolepsy. So it's falling asleep suddenly. More commonly, that's actually kind of rare. More commonly, folks will feel this irresistible drive to sleep. They just can't fight it. They fall asleep for a few minutes and then they wake up again. And that's also more commonly what we see in narcolepsy anyway, but this is a common problem with these medications. More so with the class of medicines known as the dopamine agonists. So those medicines that mimic dopamine in the brain. It can happen with levodopa as well, but especially with dopamine agonists. So propranolol or Requip, Mirapex or Pramipexole, and the other medicine called Nupro or Rotigotine. For some reason, those medicines really like to cause this. And I try consistently to screen my patients for this because sometimes they won't recognize it as such. And this can happen spontaneously. Even if you've been on a stable medication regimen for years, this can just arise out of the blue. Usually it'll happen when we're first starting the medicine or increasing the doses or what have you, but it can happen at any time. So it's an important thing to know about because obviously it's a safety issue, especially if you're still driving. So if that happens, you stop driving, you call your neurologist right away. Really important. An important thing to be aware of. Let's see. Oh, I think I bumped something here. 2 seconds. We're back on schedule. Okay, so excessive daytime sleepiness. How do we go about treating these things other than some of the things that we talked about? But exercise. As many of you know, I harp on this all the time. Physical exercise. So aerobic exercise, strength training, stretching, balance exercises, a comprehensive exercise regimen is really important in managing symptoms of Parkinson's disease. Not just physical symptoms, stiffness, slowness, tremor, and so on, imbalance. It's critical to those things, very real and concrete, as many of you know, but also for many of the non-motor symptoms we struggle with, including mood and anxiety and blood pressure problems and so on, but also sleep. And so exercise really has a very prominent awakening effect on most of us, such that there are some folks where you can't exercise within 2, 3, 4 or more hours of bedtime because it just has such a awakening effect. Some folks can exercise and then fall right asleep and they're fine, but it more often than not has a very awakening effect, and we can leverage that to our benefit, especially if we're struggling with just being drowsy all day long. So exercise is important. Bright light wakes our brain. It stimulates our pineal gland, which releases melatonin and a number of other things, but bright light wakes us up. And we all evolved in the context of no electric lights, no candlelight, and so on and so forth. So we're awake when it's bright, we're sleepy when it's dark. And so bright light, especially in the afternoon, can really help folks get through the later part of the day. There's some folks where we're just really sleepy through the entirety of the afternoon and into the early evening. and just can't get going. And so sometimes, again, medicine side effects and so on. But getting bright light, getting outside for a good chunk of time can really make a difference. In the darks, winter months when we have less daytime light, when it's cloudy and so on, things that we often can utilize are full spectrum light boxes, like what we prescribe sometimes for folks with seasonal affective disorder. Basically, it kind of mimics the full spectrum of light that we get from the sun. And sitting in front of that, reading a book for 15, 20 minutes early in the day, maybe early or mid-afternoon, that sort of thing, can make a huge difference for some folks. So these are some strategies that we use. Not just kind of weak fluorescent light, like genuine bright light. Think of yourself as a plant. Plant's not really going to get enough, sort of full spectrum or intensity of light from just regular indoor lights. Kind of think of it that way as a rule of thumb. Scheduled naps, kind of talk about this already. Again, I really like scheduled naps in the early afternoon, just in general, but especially in Parkinson's disease. It can have a huge and very concrete effect, because another dynamic that is common and we don't really understand the mechanisms is that many times my patients will say that, doc, I'm keeping with the schedule of my medicines, and it just doesn't feel like my medicines are working quite as well in the afternoon. My tremor is worse, my slowness is worse, my unsteadiness is worse, my freezing is worse, what have you. My medicine doesn't last so long, etc. It's a hugely common problem. We don't understand the mechanisms. Sometimes a scheduled nap can really have a big counteracting effect on that. Again, everyone's different, but these are trends that I see. Adjusting meds, formulations, we talked about all of that already. I won't beat that horse to death anymore. Caffeine, question mark. Caffeine can help, especially with kind of sleepiness in the morning, obviously. It kind of wakes up our brain, but we tend to see that folks kind of become dependent on caffeine if they're regular caffeine drinkers, myself included. And so we don't get as much of that awakening effect. In general, when we're more used to caffeine, also, generally speaking, we don't want to be drinking caffeine in the afternoon hours and beyond, unless we're using it just occasionally, sort of strategically. Because caffeine, even once those initial sort of buzzing effects have worn off, half-life is long enough that it can often interfere with your sleep, getting to sleep in those early sleep cycles and the quality, getting into those deeper stages of sleep. It's kind of hanging out in the background, getting metabolized. So we want to use it judiciously. If we have a function to go to or a dinner to go to or something like that, we can have a half cup of full strength coffee and kind of utilize that for a single time, but we don't want to be making a habit of it. Medication additions, I kind of talked about this briefly. Occasionally, we will use medicines that are active stimulants. So things like Ritalin, for example, or modafinil, or these medicines that are either derivatives of amphetamine class medicines or similar to them, that we use in the context of other diseases. It's a rare thing. The data are not great, kind of mixed. Occasionally, I will use these really when our backs are up against the wall and I have someone where they really can't tolerate any form of dopaminergic medication because it just knocks them out. And sometimes we just really need that medicine to help with motor symptoms, and we have to counteract it actively. So, sparingly at absolute most. In the context of Parkinson's, more specifically, there's a couple of medicines that we use to help kind of boost dopamine. So there's a medicine called selegiline that we often will use to help dopamine hang around longer in the brain. That medicine gets broken down into kind of amphetamine derivatives, and it can have kind of awakening effect. So we can sometimes utilize that to our advantage, usually not hugely so. Usually it's more of we need to avoid taking that medicine too close to bedtime because it can keep people awake. So usually dosing that, early day, midday, no closer to bedtime. These are things that we think about. Amantadine is a similar medicine. A medicine that we sometimes use for cognition in Parkinson's and in totally different disease, Alzheimer's, is something called donepezil, or Aricept is another name for that. Some people find that medicine really having an awakening effect. For some reason, the default way to prescribe that, or it's recommended, is at bedtime. I always prescribe it and have folks take it first thing in the morning. Sometimes people find it really wakes them up. So those are some nitty gritties. All right. So I think we're staying on time. I want to make sure that we have enough time for questions. But these are kind of the shorter last two topics. That's kind of the meat of the talk, what we just talked about. So these are a little bit more specific. This phenomenon known as REM sleep behavior disorder, or RBD for short. This is a common, not ubiquitous, but a common problem in Parkinson's. So what is this? So when our brains are asleep, we go through a phase as part of that sleep cycle called REM, rapid eye movement. So this is by and large the phase of our sleep where we are dreaming. And normally when we are dreaming, our bodies are kind of naturally paralyzed so that we don't act out our dreams. But a very common component of Parkinson's disease and a few related diseases is this phenomenon where that system is affected, where we still have our REM sleep, but our bodies aren't paralyzed like they normally are. And so we can kick and punch and call out and talk and do all sorts of dramatic things, sometimes leap out of bed, punch our bed partners, and folks come in with bruises and bed partners come in with black eyes and all sorts of things. And this is a component of Parkinson's disease itself. Sometimes this precedes the onset of Parkinson's symptoms by years or decades. Sometimes it only happens right at the onset of symptoms. Sometimes it happens later on. Sometimes it never happens. But it's a component of the disease itself. There are some medicines that in normal healthy individuals we can trigger this. But by and large, when this just happens spontaneously, it's often a prodromal component of Parkinson's or a couple of other very similar diseases. So really, this is most folks who have this, they're completely unaware. They're fast asleep. It's not hallucinations. That's a totally different thing. Folks often mix those things up. It's dreaming. It's dreaming. And sometimes people will have very vivid, very realistic dreams associated with this, but not always. Often the dreams are, have a kind of a component of either chasing or being chased or fighting, or there's this trend of that sort of those themes, but not always. But whether you remember the dreams or not, people are not aware of this. And so really, even though this can sometimes interfere with sleep quality, if it's really prominent or folks are, getting injured, leaping out of bed, the main dangers of this are physical injury to yourself or your bed partner. And so some people just sort of fuss and talk or scream out loud, but they don't really move. But some people can leap out of bed and break bones or furniture or get lacerations or put their fists through windows and things like that. I've seen everything. So really, the way we need to manage this is by making the environment safe. So both for you and your bed partner. So sometimes we need to sleep in separate beds. Sometimes all we need is just a bigger bed or a big sort of body pillow as a sort of a great wall in between the two. But sometimes we really need separate beds or even separate rooms. Sometimes we need to get rid of the bed frame and put the mattress and or the box spring close to the ground and have mattresses on either side so that if we roll out of bed, we're not landing on hard floors or what have you. Moving furniture away from the bed so that there's not sharp corners we can hit our faces on and so on. Moving the bed away from windows. It's rare, but these sort of things can happen. This is different than sleepwalking. Okay, so people generally don't get up and walk around and do complex things or raid the fridge or things like that. That's sleepwalking. That's a different phenomenon. This is just non-specific, usually kicking, punching, calling out, screaming, sometimes bloody murder. People are totally unaware of it unless it is so bad that it wakes them up and then they wake up and, oh, I was having a bad dream. That's about it. So safety is important. Exacerbating factors. So caffeine will sometimes exacerbate this. Alcohol too close to bedtime can exacerbate this. The biggest thing are antidepressants, which is a real problem because we often use antidepressants for very good reasons, but sometimes that can exacerbate this, as well as restless leg syndrome. We'll get to that in a second. But sometimes our medications can amplify this, like levodopa rarely can. Sometimes levodopa will help this, not commonly, but it can. So there's some things we try to limit. If we have untreated sleep apnea, sometimes that can exacerbate this as well. So there's a bunch of things we go looking for. Medicines, there's really only a couple of medicines that we often utilize to specifically treat this. One is supplementing melatonin, which helps in maybe a quarter, some odd of folks. The data are not great, but in clinical practice, I do see that some folks will find that melatonin makes a huge, clear, and definite difference. The dose at which it does is variable. So usually I'll start folks on kind of small doses, 3 milligrams at bedtime, do that for a week or two, and then work our way up until we find the dose that helps. Or if it doesn't, by the time we get to about 9, 10 milligrams at bedtime, if it's not helping at that point, it's probably not going to. The main side effect of melatonin is daytime drowsiness, so that's the main thing to watch out for with that one. But generally speaking, it's pretty benign. But it's benign, it's over the counter, it's inexpensive, it's ubiquitous, so it's usually the first thing that I will try if we need to treat REM sleep behavior disorder with medicines, which we don't always. And then the other thing that we tend to use, if that fails and we're really at risk of injury, is a medicine called clonazepam, which is a long-acting sedative medicine, clonazepam or Klonopin. And there's problems with that medicine. We sometimes use it to help with sleep maintenance as well. Sometimes use it to help with sleep maintenance and with REM sleep behavior disorder and kill a couple birds with one stone, so to speak. But it's a very long-acting medicine. And so it can worsen daytime sleepiness and imbalance during the day and cognition. So we try to use this very judiciously and at extremely low doses, because our brains tend to be much more sensitive to that class of medicine as we age. So we're in the home stretch. Restless leg syndrome, or RLS for short. So this is a common problem in and of itself, but it tends to arise maybe a little bit more commonly than in the general population in Parkinson's disease, especially more moderate to advanced Parkinson's disease. They are completely different phenomena. They're not really pathophysiologically related in the brain, as far as we can tell. But so what is it? Restless leg syndrome, as many of you likely know, is a phenomenon where we get this really uncomfortable sensation in some part of our body, usually in kind of the geographic region of our legs, below our waist, but it can happen anywhere in the body. So RLS, restless leg syndrome, is kind of a misnomer. It's technically called Willis-Ekbom syndrome. It can happen in any part of the body, but for some reason, classically in the legs. It has nothing to do with the legs themselves. It's a brain circuitry problem. But it causes this really deep discomfort, the sense that you have to just move your legs, often your calves or your feet, either kind of a crawling or ants crawling sensation, or just difficult to describe. Rarely people feel it kind of cramping or painful, not usually painful, but there's a whole spectrum of ways in which people describe this. And it's a very common problem. Funny enough, in this disease, in folks who don't have Parkinson's disease, say someone comes in with restless leg syndrome, one of the most helpful classes of medicines we find that helps with the symptoms are medicines that mimic dopamine in the brain. Again, it's not related to Parkinson's, but those medicines help with this symptom. There's other medicines as well, but that's the main class of medicines. The problem with them is that if you take someone with restless leg syndrome and you give them these medicines that mimic dopamine, so things like Requip and Mirapex and so on, they help with the symptoms, but over the course of months and years, they often actually end up worsening the restless leg syndrome. It's called augmentation. And so it's a double-edged sword. We treat the symptoms and then we make them worse, and then people are absolutely miserable. It's a real problem. It's difficult to treat. And so one of the theories is that we take folks with Parkinson's disease, they may have little or no restless leg syndrome, or maybe just a skosh, they don't really realize it. And then we treat you with levodopa and dopamine agonists for years, and then we wonder why we develop restless leg syndrome later on down the line. So maybe we're kind of augmenting it into practical reality in folks with Parkinson's disease. We don't really know. But it's a common problem because medicines like levodopa will treat the symptoms, but especially levodopa will actively worsen them over time. So it becomes this vicious cycle. And we need medicines like levodopa in Parkinson's, obviously. So can be a really challenging thing to treat. So that's kind of the brief relationship to Parkinson's disease. So what are the ways we try to treat this? Well, number one, there's a clear relationship between relatively low levels of iron in the brain and these symptoms happening or being worse. The physiology is not completely understood, but we know that there's a relationship there. And so often one of the first things that we check is, are your iron levels relatively too low? Because if they are, replacing iron levels in iron stores, I should say, in the body can sometimes help or even resolve the symptoms. Sometimes not, but it's one of the first things we do. Exacerbating factors. So there's a lot of different medicines and other substances that can worsen RLS. Let me back up a touch. RLS is related to our circadian rhythm. So it's typically most prominent or only happens in the evening hours and overnight. If we worsen it over time with medicines, it can happen earlier in the day or affect other parts of the body or happen throughout the course of a whole day. It can be a nightmare. But classically, it's something that happens typically in the afternoon and evening hours. And it's something that arises when you're seated, when you're sitting still, when you're sitting in your recliner, and especially if you're laying down in bed. You get up and move around, the symptoms go away. That's how RLS works. It's a funny thing, but we want to avoid exacerbating factors. So, too much, sitting around for hours and hours, leading up to bed can worsen that. Some of us don't have that option not to do that. But medicines, so antidepressants can either trigger this or very much worsen it. Again, it's a real challenge, but that's a classic problem. Antihistamines, so over-the-counter medicines, Benadryl, anything with PM in it, ZQuil, etc., classic problems. Alcohol, caffeine, all of those will classically exacerbate this, so we want to limit those things. Getting more iron in our diets. Sometimes we have to actively supplement iron with iron pills. These things we have to think about. Conservative strategy. So we find that stretching the muscles of your legs right before you lay down to bed, doing a very little bit of light exercise can help. Weighted blankets, hot water from a shower or a bath for a few minutes before you lay down to bed. Making sure your legs aren't too hot under the blankets during the hot summer months. All these things can sometimes help. Usually they're just little bits, but sometimes a lot of little bits can add up to a lot and help folks get to sleep. Because once you're asleep, it goes away. So this is a problem when you're awake. We can still move our legs and kick and that sort of thing. That's a different phenomenon, but this is a problem of a subjective sensation where we're awake. Sometimes we need to treat with medicines, like I kind of mentioned, but the best medicines for treating this, by and large, are medicines that are or mimic dopamine, but they can worsen it over time. Not in everybody, but it's a common enough problem. Medicines like gabapentin and a close cousin, something called Lyrica or pregabalin, those can help, often to a variable degree, but for some reason, those don't seem to worsen the symptoms. So that's usually the first medicine I will try. They can sometimes make folks sleepy and help with getting to sleep as well. Augmentation, we just talked about. Okay, so a few final tips and takeaways. Just in general, pay attention to timing and trends of your symptoms during the day. That's true of many things in Parkinson's, as many of you know, but especially when it comes to sleepiness, both daytime sleepiness and sleeplessness overnight. Paying attention to when these things happen, are they related to timing of your medicines and that sort of thing? All that kind of stuff can help folks like me sort out how to address it. So looking at trends is really important. Sometimes these things vary, but kind of looking at symptoms over the course of a few weeks or even months and getting a sense for the forest for the trees can really be helpful to help you address them. And that's all kind of the first 3 points there. Exercise, exercise, exercise. I can't emphasize it enough. Even if it's a little bit, some is better than none. And it's never too late to start. No matter our mobility or anything, there's always a way that we can find to get our heart rates up and move our bodies. And that goes for sleep and for Parkinson's disease. So if I can only have one single slide in any of my talks for Parkinson's disease, I would introduce myself and then it would just say exercise across it, and then it would be thank you, any questions. So if I can only limit it to one. And then don't be afraid to experiment with timing, with adjustments to medications, to timing and adjustments to your schedule. Some people will find that levodopa makes them sleepy. Some people, occasionally, will find that it keeps them awake. So if we're having a hard time getting to sleep at bedtime, right after we take our evening dose of levodopa, maybe we hold that for a few days and see what happens. You see what I'm saying? So we need to be flexible. We need to experiment a little bit in a methodical fashion and with your doctor. So that's kind of the approach. So, all right, I'm done throwing stuff at your heads. That's our talk. Thanks for your attention, and we will get to questions right now. Yeah. So after you, sir.
If we're considering using the Inspire system as an alternative to CPAP,
yeah,
is there any correlation between Parkinson's and that system?
No, so let's talk about that real quick. So the question was in the context of sleep apnea. So most of the time we treat sleep apnea, our first line treatment for sleep apnea, where we can't just kind of position your body and solve it that way, is using a medicine or using a device called a CPAP, continuous positive airway pressure. Basically, it's a little air pump connected to a hose, connected to a mask that goes over your either your nose or your mouth and your nose, and it pushes a little bit of air into your, basically down your airway, and it mechanically splints open those soft muscles of your throat, right? And that is a simple and effective way, an adjustable way of treating sleep apnea. But a good chunk of folks can't tolerate that. And so recently there's been development of a peripheral nerve stimulator device, basically a little implantable device. It goes underneath your skin that's attached to one of the nerves that kind of controls the muscles of our tongue and throat, that can sense when those muscles are getting too lax and then kind of give them a little jolt and kind of wake them up and open them up. And so it's a nice option in folks who are surgical candidates, can't tolerate the CPAP no matter what, that sort of thing. But that's a relatively new development, and it's not something that I would expect to have any impact on Parkinson's disease one way or the other in terms of symptom control, that sort of thing. I'm certainly not an expert in it, but it is a nice option for some folks, especially if we have really severe sleep apnea, we're really symptomatic, we can't find other conservative strategies to manage it, and we can implant that. So
I was also thinking the other way. Parkinson's have any effect on the success?
To the best of my knowledge, I wouldn't expect it to. Again, I'm not as well versed in that system. It's something that again just came to market relatively recently. I've had a handful of folks who ended up having that, both with and without Parkinson's disease, but I wouldn't necessarily expect a huge impact. Obviously, that sort of situation would be different if we had something like deep brain stimulation in place. But by and large, I wouldn't expect too much in the way of troubles with that. Good question. Other questions? Yes, ma'am. So his sleep is being interrupted by a sense of itching through the course of the night, or a restless feeling? Okay, so that sounds to me. So if he gets up and moves around, does that get a little bit better? As you mentioned that. So that would be the first thing to ask, because that kind of internal, difficult to describe heebie-jeebie sensation sounds like restless leg syndrome to me. Again, it's a misnomer. It most commonly affects this geographic region of our legs, but it can affect any part of the body or just kind of globally. Again, the more technical term is Willis-Ekbom syndrome. That's not as easy to say. Um, so that's one of the first things I would think about. Timing when it happens is important, like I mentioned. Relationship to medications as well, because again, our Parkinson medicines will treat restless leg syndrome too. And so wearing off of medicines can both cause discomfort from motor symptoms reemerging, but also restless leg syndrome reemerging too. So these are some of the things I would think about, first. So as much detail as to what he feels, when he feels it, when it gets better, what does or doesn't make it feel better. If he has to get up and move around and he feels great and then he lays down again and it happens again, that sounds like RLS. So those are the things I would think about. Yeah, if that helps. Yes, ma'am. Oh, pardon me. Yeah. So the question there, yeah. So the question there was an individual spouse having trouble with a deep sense of sort of discomfort, difficult to describe, kind of a heebie-jeebie sensation internally, limiting their ability to sleep. And so that one of the first things I think about with that kind of description just off the cuff is restless leg syndrome. Again, restless leg syndrome is not something that always just affects our legs. It can happen anywhere in the body, especially with augmentation. So those are some of the things I would think about. Yeah. Thank you for reminding me of that, of repeating the question. Sir. Yeah.
Yeah. I have a problem waking up in the middle of the night, but the dopamine wakes me up.
Yeah. Yeah, that can be a real challenge. So one of the first things is it a problem? So if we're waking up in the middle of the night and we have to get up and do something for an hour, and then we're able to get sleepy again and go back to sleep, that's actually okay. Right? We don't have to, if we can't get back to sleep for 15 or 30 minutes or what have you, it's not necessarily the end of the world. But one of the key things that I didn't emphasize that I should have is, this is kind of the number one thing in sleep hygiene, is if you wake up in the middle of the night and you're just sitting there and you can't get back to sleep, and you're just awake, don't stay in bed. Get up and get out of bed. Because if we just stay in bed and we're asleep and then we're just miserable and thinking about, I can't get to sleep, the more we can't get to sleep, the more we can't get to sleep. And then we associate bed with, this horrible feeling of not being able to get to sleep and insomnia. So 10, 15 minutes, just get up out of bed, go, turn on a soft light, listen to music, read a book, what have you. And that's often one of the first things. Often conservative strategies are one of the best strategies, in my opinion. If that fails, or if you're waking up and you tried that and can't get back to sleep for 2 or 3 hours or what have you, and that's a real problem, then that's when I start to look at medications that actively help with sleep maintenance. I kind of glossed over that before. Most of our medicines help with getting to sleep in the first part of the night, but don't really help us over the course of the night. Or if they do, they cause too much grogginess the next day, like clonazepam is a classic one. So that's when I look at certain types of antidepressant class medicines, older ones, that have at low doses a lot of effects that block histamine in the brain, which makes you sleepy, but not as much blocking of other chemicals in the brain. So one of the classic things you find in all over-the-counter sleep medicines is Benadryl, diphenhydramine, and a similar medicine. And the reason Benadryl makes us sleepy is it's an antihistamine. When you block histamine receptors in the brain, H1 receptors in the brain, it makes you sleepy. When you block them outside of the brain, it helps with symptoms of itching and allergies and all that sort of thing. The problem with Benadryl and other first-generation antihistamines, the drowsy antihistamines, and some of the non-drowsy ones too, is they block other chemicals in the brain that affect cognition and can cause hallucinations and all those sort of things. So if we can find medicines that block those histamine receptors without causing too much havoc otherwise, that can help with sleep maintenance. So things like doxepin, nortriptyline, trazodone, these are some of the medicines I look at low doses that can sometimes kind of skirt that line of helping with sleep maintenance over the course of the night, but being well tolerated as well. So those are some of the thoughts that I would look at. Yeah, conservative strategies first, and then we lean on medicines if we need to. Sir, you had a question. Did I see your hand up before? Did you have a question?
Sleep all the time, day or night. No difference.
Yeah.
What's causing all that?
So by and large, so the question was, um, you're experiencing, excessive daytime sleepiness 24/7, or excessive sleepiness 24/7. You sleep overnight, and then you're sleeping a lot during the day. It sounds like, and just consistently sleepy. And so by and large, that's a part of the disease itself in many folks, especially, again, more advanced age, more advanced Parkinson disease. But we always need to start troubleshooting by looking, are there any trends? Is there any timing? Do we need to try switching, versions of levodopa, for example? Are we accentuating that underlying disease process that we don't have a lot of control over? Are we accentuating that with medicine side effects and things like that? So those are some of the things that I think about in that situation, if that helps to make sense.
So you take me as a patient.
Mm-hmm. Yeah, and we need to sit down and review that again, but just kind of for the group, those are the things that I think about when we're dealing with one of those patterns that we mentioned of feeling sleepy 24/7. The reality is that sometimes it's a really challenging thing to treat. Sometimes if it's such a problem that we're just drowsy and sleeping throughout the course of the day and night, we need to consider medicines that have a waking effect, but they don't tend to work all that well. But we'll review that again later on. But it's very good to highlight that personal experience so we can talk about it in a little bit more detail. Let's see here. We have about 10 minutes, I think, before folks have to run off to lunch. So I want to get to other questions. Yes, ma'am.
Go to sleep. I think one, I think two. But if I wake up, within a short time, is it okay to take another one? Does it give you enough time to get good sleep enough to pick up healthy?
Yeah, so it depends on the timing and it depends on the dose, is what I would say. Trazodone in some individuals helps both with getting to sleep and then staying asleep. But in some individuals, it really only helps with getting to sleep and not as much with sleep maintenance. Everyone's very different. And so one of the first things that I think about, if we're tolerating a low dose well, but we're getting to sleep and then waking up still again and having trouble with sleep maintenance, is increasing the dose cautiously, like the initial dose, so that we don't have to wake up and redose. We can, but the later you dose any kind of sleeping medicine in the middle of the night, you're going to be drowsy the next day, right? And then we can get into a vicious cycle. So increasing the dose cautiously in the early part of the night and see if it helps. But if we're still just getting more sleepy in the early part of the night, getting to sleep fine, but then having trouble with sleep maintenance later on, and if we've addressed, like we talked about before, you and I, medicines in the middle of the night, levodopa and all that sort of thing, then maybe we need to try a different class of medicine because everyone's physiology is different. So yeah, it's again, troubleshooting. That really is one of the take-home points here. Everyone is so very different. You had another question, sir?
You mentioned drug called cognition. You said something.
Donepezil,
How do you
DONEPEZIL. Yep. The brand name for that is Aricept, part of a medicine class. There's a few others in that class. That's one of the most common, and it's we use it to help with cognition in folks with significant cognitive problems and more advanced Parkinson disease. But again, some folks will find it having an awakening effect. It's not in everyone by any means, but there's a chunk of folks where we really find that. And so as a rule, I really try to dose that first thing in the morning rather than at bedtime. So for example, in my electronic medical record, when I go to prescribe that medicine, the default is at bedtime. And that's a really classic thing. When other docs prescribe it, they're not really familiar with it. I see that all the time. And so, I always try to move it to the morning because sometimes it can just keep people awake. Simple as that. ARICEPT, Aricept. Been around for a very long time now. And that kind of goes for that class of medicine. Other questions? Sir?
Can you tell me the difference between essential tremor?
Essential tremor, and so the question is, can I briefly discuss the difference between essential tremor and Parkinson's disease? So these are both diseases of the brain. Essential tremor is a disease that is a poorly understood disease that primarily is characterized by tremor, as it sounds. But the characteristics of the tremor are typically different than in Parkinson's disease. It's a disease that, similar to Parkinson's, slowly sort of creeps up on us, often later on in life. So whereas the most common age to develop Parkinson's disease is around 70 years old, essential tremor happens either early in life, in our adolescence or teens, or a little bit more commonly in our 50s, 60s, 70s, and beyond. Why that is, we don't know. It's, by and large, we think a genetic disease, likely a number of different diseases that all look very similar rather than a monolithic disease, but we still don't know. And it's a disease where brain cells don't break down. They don't seem to degenerate the way they do in Parkinson's disease. Parkinson's disease, brain cells in certain parts of the brain are damaged and lost, and that leads to symptoms. In essential tremor, this is more of a problem with certain brain cells in certain loops, developing an abnormal pattern of firing. They're talking to each other in a way that they shouldn't be, and that leads to this oscillatory contraction of muscles, usually in our arms. And that leads to a tremor in, by and large, the hands. You can develop tremor anywhere in the body with essential tremor, but by and large, it's a disease of slow onset and slowly progressive action tremor. So usually the majority of the tremor is when we're using our arms, our hands, or our body part, engaging the muscles. In Parkinson's disease, we have action tremor as well, but the majority of the tremor in folks with Parkinson's who have tremor, because not everyone does, we develop a tremor at rest when our muscles are loose and relaxed, either when we're walking or what have you. There's a lot more detail in all that, but these are the broad strokes, right? And so Parkinson's disease, while tremor can be a component of it, it's a variable component. The core symptom of Parkinson's disease is something called bradykinesia, so slow movement, by and large. There's more to that, but that's the core component of all Parkinson's disease. Tremor is a plus-minus thing, and the characteristics of the tremor are different. The underlying physiology is different, and the treatment strategies are different as well. Prognosis is different. So where they intersect is that they can happen at similar times of life. They're gradual in onset, and sometimes we can get fooled by thinking one is the other, even in the hands of experts. And so it can be a challenging diagnostic problem because there's really no solid tests for either of these diseases. There's one special type of brain scan that can help us distinguish between the two diseases. It's imperfect, but that's that in a nutshell. Hopefully that helps. There's always more to say about these sort of things, but those are kind of highlights. All right, guys. So other questions in the last few minutes? I want to make sure I get to everybody as much as possible before we all boil to death. I'm just kidding. It's a little bit warm. Yes, please. Mm. Yeah. Yeah. It's a really common problem. One of the first things that I think about when someone, especially if they're really referencing a part of their body, is, are we adequately managing the motor symptoms? Because sometimes fatigue is fatigue, but sometimes, again, that core component of Parkinson's, bradykinesia, slowness, folks don't come into my office and say, Doc, I'm bradykinetic. They say, I feel weak, or I feel fatigued, or my muscles feel fatigued, or I don't feel like I can hold my body up as well as I used to. These are the ways that we experience this phenomenon, because Parkinson's damages circuitry that is unconscious and automatic, right? And so it's something that we're not immediately consciously aware of. We feel it in this other way. So yeah, especially with that sort of symptom, but fatigue in general, sometimes it's a problem with underdosing of levodopa. Or other dopaminergic medications, or wearing off in between, or what have you. Rarely it can be a problem with things like low blood pressure, right? So sometimes if we have low blood pressure, which is a common problem in Parkinson's disease, both because of the disease and because of the medicines we use to treat the disease at lower blood pressure, sometimes if our blood pressure is low enough to cause symptoms, sometimes we just feel, I just feel fatigued or I feel weak, but it's not quite bad enough to cause outright lightheadedness or dizziness, you know, sometimes it is. So those are some of the things I think about. Low blood pressure, you know, overdosing of the medicine, accentuating that, underdosing of the medicine. Those are really some of the things. And then, you know, doing an exam and getting a sense of, okay, do we have genuine weakness? Do we have a radiculopathy or a cervical spine issue, or have we had a stroke in the meanwhile? And it's just a vague sense of weakness. You see what I'm saying? Those are some of the things I think about. Or sometimes people just say, I feel unsteady and weak on my feet. And what they mean by weak is they feel imbalanced. And that's a core component of Parkinson's, but sometimes that's because we have neuropathy as well, and we can't get our feet under it. So these are all the things I think about with that. It's a great question. And there's no simple answer. There's really an algorithm we have to kind of work through by really detailed history, is there timing, et cetera. That'll be related to medicines. Is it just in general, exam, all that kind of stuff. And then sometimes just trying things. Um, yeah. After doing some of the basic, the basic troubleshooting is okay. Or I take my dose of levodopa when I wake up at 6 a.m. and then by mid morning, my next dose is at noon. But by mid morning, I'm just really feeling weak. I just don't have it in me. Okay, so are you feeling that medicine? Do you feel like your tremor is getting a little bit more prominent, or is your wife or husband noticing that you're slowing down or scuffing your feet more, or your feet sticking? Our medicine is wearing off. We need to, increase the dose, narrow dosing, add, adjunct medications, those sort of things. Those are some of the ways that I try to, the basics I try to approach it with. So that's a great question. So yeah, again, looking at trends, at timing, that's always the first thing. That's such a core component of managing so many symptoms and troubleshooting so many things in Parkinson's disease. Motor and non-motor is looking at the timing, because we're so reliant on medicines that are short acting, right? And so there's this constant up and down. It's a constantly moving target. So anyway, you see what I'm saying? Hopefully that helps answer that. Other questions? Yes, please. Mm. Okay. Mm. Yeah. Yeah. It's a good question. Not that I'm aware of off the top of my head. I'm not the most plugged in uh, individual, especially as far as kind of the larger trends in the Denver metro area. But yeah, sorry, the question is, so a very prominent physician, Sanjay Gupta has been kind of championing. That's a difficult word to say. Trying to promote this concept of preventative neurology and general brain health, right? So we kind of in a similar vein to what came out of the Framingham study, many decades ago, in terms of preventative cardiovascular health. Like, how do we get ahead of cardiovascular disease? We used to take it for granted that folks would have, heart attacks later on in life and then just deal with it. Well, then we did this very large study in the Northeast looking at vascular risk factors and what contributes to the risk of heart attacks later on in life. Then we identify all these things like high blood pressure and high cholesterol, and the list goes on. And so then, over the ensuing decades that we now take for granted, we think about heart health. And so we're just kind of getting into this concept of how do we think about brain health? Are there things that we can do to prevent, deterioration of cognition, age-related or otherwise, or anything we can do to prevent, neurodegenerative diseases like Parkinson's and Alzheimer's and that sort of thing. And so Gupta has really been focusing on that. And so that's kind of the background to that very good question. So I'm not aware of folks who, but they're very well may be, focusing on that. Ideally, really all of us should be, primary care and neurologists like myself as well. It's more of a nascent concept than it is actionable information at the moment. With some exceptions, there's emerging data to suggest that diet, exercise, these lifestyle factors likely have a big impact on later risk of neurologic disease, especially cerebrovascular disease, stroke, vascular dementia, and things like that. But likely neurodegenerative disease as well, like Alzheimer's disease. So that science is emerging and developing right now. So really, the initial concepts can kind of be summarized to the best of my knowledge as the same things that we're looking at as far as cardiovascular health that we know, minimize complications and extend life, really apply to the brain as well. The brain is not separate from the rest of our body. So diet, exercise, these things, really seem to make a big difference, but there's a lot more to come from that. That's kind of the most I think I can, jump into that topic without just making stuff up. But it makes intuitive sense now, but there's a lot more to come from that, I'm sure. So if I come across something, I'll let you know if someone's really focusing on that. But this is something that like Gupta and a few others across the country have really been trying to bring to the forefront, appropriately so. He talked about this at length at the American Academy of Neurology this last spring, which was a great talk. That may be online, I don't know, for the general public to go look at. But anyway, he's talked about it in a number of different venues, so worth looking at. Anyway, hopefully that helps answer that a touch. Other questions? Sir? Yeah, so touched on that very briefly. Light therapy can help with kind of excessive daytime sleepiness. So using things like light boxes designed for, kind of nominally designed for, light therapy. When we think of light therapy, most of the time when we're using bright light in medicine, it's to treat either seasonal depression or certain dermatologic problems, skin problems. That's a little bit different, but anyway, yeah, light boxes can help with and just getting out in the sunlight. Really, that's the ultimate light box with being drowsy during the day, especially in the afternoons and that sort of thing. In brief, other questions? I'll get to you and then you, sir.
You have a Parkinson. COVID. Seems like I know COVID be a lot on research. Does having Parkinson's does it affect all the muscles that make it harder to be?
Yeah. So the question is it harder with Parkinson's disease to recover from things like COVID-19? Short answer is yes. So, but it's not really unique to COVID-19. So in all neurodegenerative diseases, Alzheimer's disease, Parkinson's disease, DLB, and so on, our brains and our bodies are always compensating for the effects of the disease, right? At multiple levels. And so anything that throws off our physiologic state, any kind of physiological stressor, whether it's minor, like losing a night of sleep or being under a lot of stress because of a family problem or what have you, or something much more major like COVID-19, influenza, a UTI, a surgery, a fall and a broken bone, anything like that will reliably worsen Parkinson's symptoms, even if we change nothing else. Meds are the same, doses the same, timing and all that. Tremor is worse, I feel more unsteady, and so on and so forth. And so that's just a part of our body can only juggle so many balls in the air at once, is kind of my favorite way of putting it. And so this is also kind of to piggyback on that when folks with Parkinson's are thinking about having to undergo a big surgery. Both the physiologic stress from that, the effects of anesthesia and so on, it can be harder for folks to recover, as many of you likely know. Things like where you have to think about, a knee replacement or shoulder surgery or anything, it can be harder for folks to recover from that. And so it's something that we have to take into account. But is there anything special about Parkinson's and you're recovering from COVID or even susceptibility to COVID? Doesn't appear to be so, but that's just a general concept. So it's a good question. You had another question.
When you talked about dyskinesia, you mentioned stiffness and slowness. What about just plain aches and pain? Is that part of
Yes.
dyskinesia?
So let me be clear. So dyskinesia is kind of the opposite of stiffness and slowness. Funny enough. So when we treat folks with Parkinson's disease with medicines like levodopa, we have a lack of dopamine in the brain. We're trying to put dopamine back into the brain, and think of dopamine as this oil in this engine that helps us move our bodies. This is a great metaphor I like. And so we can help recover that stiffness and slowness, improve the way our bodies are supposed to move. But as the disease progresses, even though that effect always maintains, so the dopamine will always help, it gets more complex for some folks. So there are some folks who will develop excess. So we will always get improvement in stiffness and slowness, and for many people, tremor with dopamine or things that mimic it. But in some people with more advanced disease, because the brain is changing, we get these excessive symptoms. We get excess movement along with that improvement in stiffness and slowness. So we get what's technically called levodopa-induced chorea. We just kind of shorten that to dyskinesia. So those are these dancing, flowing, movements like this, sometimes affecting just the foot or the whole body or anything in between. And it's excessive movement. And that's what dyskinesia represents. And that's a peak dose side effect of levodopa and similar medicines. And most of the time, folks, if it's mild, moderate, folks don't even notice it. Their spouses will notice it. They don't notice it. That's a common thing. And it's not dangerous in and of itself. If it's just there, they're not bothered by it. If it's not causing, impacts on their balance, if it's not so bad that they're throwing off your balance or things like that, then I don't care about it. But sometimes it can be uncomfortable, and it can, we all get arthritis as we age, and so some of us more so than others, unfortunately. And so if we're moving constantly, we don't have any control over this. This is an automatic thing. That can put a lot of stress on our joints and on our muscles, because our muscles are constantly moving. We're getting a workout all the time, and that can be painful sometimes or uncomfortable. And so that's kind of the intersection between those things, if that helps make more sense of that. Yeah, that's a great question. All right, maybe one more question, then I have to pass it off to my colleagues. Ma'am?
What about sound therapy?
Sound therapy. Yeah, so music therapy in particular is an emerging and actually fairly well established concept in terms of the overall therapy approach to Parkinson's disease. We have a few music therapists in the northern Colorado area. It can be a really fun and engaging way to get our bodies moving, to work on timing, on amplitude of movements, and a number of other things. And so that's kind of where that comes in. And so therapies are a critical component of treatment of Parkinson's. One of what I call the pillars of treatment. So meds, medications are a pillar. Exercise is a pillar. Therapies are a pillar. And I like that metaphor because that emphasizes that these things carry equal weight in managing the symptoms of the disease. And so classically, we think about physical therapy, occupational therapy, speech and swallow therapy in managing symptoms of Parkinson's. But we can really start to add music therapy as kind of one of those core things. So just to briefly speak to that. Does that help answer your question? That's kind of what I think about when you say sound therapy. Not aware of other sort of specific types of therapy. Are you thinking about like ultrasound therapy? Because that's a very different concept.
Get a room with sound, levels of sound.
Yeah, I'll have to look into that. I'm not really immediately familiar outside of things like music therapy, which can take a number of different approaches, but it can be very helpful. So okay, guys, I think I'll pass it off to my colleagues at the back of the room. Thanks for your attention. Long talk, but hopefully it was helpful. So yep.